So let's talk about patient positioning just a little bit. We position the patient to provide the easiest access to the anatomy. And in most of our procedures, the patient's lying face down. What do we call that? Anyone? Prone. Prone. What's the opposite if they're looking up? Supine. Exactly. So prone looking down, supine, I was thinking they're supine, they're just hanging out holding some soup.
Right.
Okay. So, but most of the time when we're working on the spine, they're going to be prone. Occasionally, they will be supine when we want to get to either the front of the spine and the neck for like a stellate ganglion block, or maybe a hip injection we often do from the front. We can do a hip injection on both sides. A knee, for example, is often done in the supine position. Ankle projections, foot projections are easiest because we're coming usually through the top of the foot. But just think about, whatever the anatomy is, we're often going to the front of the knee, so the front's going to be up. We're going through to the back of the spine, so the front's going to be down. And you can generally make an assumption about where the position is being patient. Sometimes they'll be in a lateral position, okay? And we put the patient in a lateral position, say if we're putting in a pump, we'll have them lie on the whatever side down, we'll have the spine exposed, and then also the belly exposed. And generally speaking, when we put in a pump, for example, it's the left side of the patient that goes down because 90% of people are right-handed. I'm going to be using my right hand as I put the needle in the spine. I don't necessarily want to be using my left hand. So it's easier for me to use my right hand, so that means the left side of the patient down. That means the right-hand side of the belly. So if you look at most pumps, they're almost always in the right belly because that's where it's big enough to place it, etc. And if you go to any other practice, about the same unless you got a left-handed doc, and left-handed doc probably put it on the other side. But the positioning is everything. It's also important to keep the patient comfortable. So if they're not, and sometimes they refuse to even roll over, right? Because it hurts them too much to lay in that position. So I would say that this is for the patient, for the most part, I can kind of get around. The one time that I really want to make the patient, I don't care about the patient's comfort as much, is when I'm putting in a spinal cord stimulator. And the reason is because I want that back to be as flat as possible. If the back is flat, you can see these what we call interlaminar spaces open up the most if they're flat. And if they're lying as they would normally, you can see that they're closed. I want as much access as possible, so I'll often ask Michelle to put 1, 2, or maybe 3 pillows under their belly, or just right under their belly button to flatten out that what we call thoracolumbar junction so we can get the needle in easily. Additionally, when we're going to the neck, if we're going to go in between, we want them to flex their neck forward, so we might even build them up here so that they have a place to let their head drop down on the table. That makes it much, much easier. But again, if they have to stay in that uncomfortable position too long, they're going to not do well. Make sure the patient goes to the bathroom before they come here too. Let's see here. All right. Generally, the concepts in terms of safety are, first, and I do it in this way because it's important, first protect the doctor's hands. Why? Because that is the thing that over time will get the most radiation. So number 1, focus on protecting the doctor's hands. Number 2, protect the doctor. And I say that not because I don't care about the staff, I love the staff, but Michelle, you can see, is far away. She's getting 1,000th of the dose that I am. Okay, so protect me. That means, ask me to stand away if we're doing the lateral. Remind me. Sometimes we get so involved in the procedure, we're not thinking. You guys are thinking about this stuff. You have the ability to look at the whole picture together. So give us some clues. Hey, doc, step back, or, I'm moving this to the side. You want to come around. I mean, it's okay. Whenever you're thinking and taking care of us, we're never going to be offended, ever. Next, protect the patient, right? And what I mean by that is cone, okay? And cone a lot. The more coning, the less radiation the patient gets. They're the other person that's going to get radiation. That's really important. Lastly, protect the staff. And it's not that you guys are least important, it's just that you're already the most protected because you're far away from the CM and distance is king. The last thing we do here, and other places can think about it, etc., is we use this lead drape, okay? And the lead drape, we put it over the patient. Now let's say we're going to do a lumbar epidural. We put it over the sacrum. And the reason we put it over the sacrum is because what happens is the scatter that's coming up here, let's say the x-ray is coming right through here, we've got to cone down, so it's not hitting this, but I can come around here and I can put my hand here and all the radiation circulation, all the light that was coming through is now stopped by this lead. And I can get my hand up quite close to direct the needle. Why it's important is that a lot of doctors will numb the skin, put the needle down, put the needle, step away, put the needle down, step away. That's a lot of steps. Nothing wrong with that. But what happens is you're not using lidocaine. What I happen to like to do, what Dr. Will likes to do is when we're using lidocaine as we advance the needle, I'll do one-handed advance and I'll have a long needle on there or even a little tubing that allows me to put my hand over here and advance and steer the needle very quickly without much exposure to my hand. So that's why we use the drape. And even more so in the neck or in procedures where you may use the fluorophore a lot, like even in spinal cord stimulation, where it may take a little bit of time as you're driving that lead up, you're going to use more fluoro. So all the more reason. This also protects the staph quite a bit. Because less, again, just imagine just like light. You have a drape, less light coming through. The one thing it does do is it does harm the patient a little extra. But since they're just in this procedure just for a few seconds, versus days for us or even years, the little bit of increase that they get is not much, but it's a massive thing for us. I always tell the patient, like, why are you wearing the lead? And I'm not, I say, it's like working in the sun. If we're working out in the sun, we're going to put on sunscreen. All they're doing is walking from their car to the mall. So they're just going to have a little bit of exposure, they're not going to get burned. But we are working in it all day long. All right. What else are we going to talk about? Procedures. So the first thing we're going to talk about is non-spine procedures. So basically we're going to talk about four: the hip, the sacroiliac joint, the knee, and then also the knee intra-articular, and then the genicular nerve block ablation. First thing is the hip. You can do the hip from two ways. Generally what we do is you have the patient lie on their back. Okay, it's probably easiest for the patient. So they're lying on their back in the supine position, like this. And you want to, what we try to do, we want to project the hip in the perfectly AP projection. So we come down, we get a picture of the hip, and then we'd see, and we can go over here to our skeleton. So what we'd see is we'd see the ball of the hip in the acetabulum, then we see the neck, then these things are called the trochanter, this lesser and greater trochanter. And basically what we want to do is project it so we see those things on the screen, because our anatomy, we start by numbing the skin over the trochanter, the inner trochanteric line, and then we come down like this. The femoral nerve and artery are coming right like here. So what the doctor generally does is start lateral, put a little bend on his needle, and then come medial, and he comes in and touches somewhere on the neck. There's a cup. So there's a sleeve all the way around. The Y ligament of Bigelow is what we call it. It wraps around that hip. So once the doctor's needle gets inside there, you inject, and you'll have a flow and contrast pattern that goes wrapping around, kind of looks like 7 rings. But generally what we want to do is position just like this, and then bring the hip in. And we never really deviate, at least here, from the AP. It's not necessary. And the same thing is if we come from the buttock and go through the buttock musculature to the hip, AP is best. The reason we like AP is because if we always use AP, we know that we're never going to project the nerve or artery over the hip, over where we're headed. If it varies, and you get used to it, and you're not used to it varying, then what happens is you come in the projection, because of that parallax, again, remember this, all of a sudden the nerve and the artery projects right over there, and when we pass the needle down, we can go through one of those things. And the patient don't like it. So we always go AP on the hip. For the sacroiliac joint, the patient is in the supine position. And this is somewhat challenging. And what we see is this sacroiliac joint is the join of the ilium, which is this big wing of the pelvis, with the sacrum, which is the base of the spine. And you can see here's what we call the base of the sacrum, the ala, the wing of the sacrum. This is L5 up here. And here's the big joint. And you can see we almost always go to the inferior portion of the joint. And the reason we go is because you can see, look at this line continues down like this. It overlaps the joint. So to get to that joint, you'd actually have to go through the whole bone of the wing of the ilium to actually get to the joint's on the other side. So we go to the base because the base, it's almost always exposed, and we can put the needle down to it. Now this needle is right in the joint. We think, okay. Now we don't know until we wiggle the C-arm back and forth in terms of obliquity, and let's say we had this projection every time, whether we were a little bit oblique or AP or oblique in the other direction. That's one bit of evidence that we know that the needle's in the joint. If we see the needle then project over here, not in the joint, or project over here, it's not in the joint, because just like our finger in front of our face is from that certain position, it projects differently. Then secondarily what we do is we would simply inject contrast. And the contrast, when it wiggles up the joint line, it's almost 100% confirmatory that you are in the joint. It may form a ball here, and if it seems to darken these lines on the inside, you can also still be in the joint. What happens also with the joint is not like many other joints. It has what we call fenestration, which is a hole, okay? And in many times, maybe 20-30% of the time, there's a hole on the other side. And the contrast, when you inject, or the medicine will fill up the joint, and it'll spill out the hole on the other side. And what's on the other side of the SI joint, gents? Any thoughts? On the anterior portion? It is the piriformis and the sciatic nerve. So that's why sometimes, let's say in recovery, we've done an SI joint injection, the patient feels weak in the leg, patient's nervous, oh no, what's going to happen is my leg always going to be this way. You know, doctor gave him an SI joint injection. It is, unless you are the super klutz of the world, impossible to inject the nerve, because there's no way you're going to put this needle all the way through that bone in that joint. The medicine got out on the front, you can tell the patient they're going to recover just fine, they just got to wait for the numbing medicine to wear off. A lot of times, and I remember TG had a patient who's like, oh no, don't worry about this, you're going to be fine. But that patient, I remember, looked alarmed. She knew, because we'd done an SI joint injection, there's no way this is an issue at all. We just got to wait. And a lot of times, if you just reassure the patient, then they don't become vasovagal and escalate into something big. But this is the SI joint. Generally speaking, what will happen is we'll toe a little bit, like we said, and if you can look over here, Helene. So I will, because of that angle of the joint, like this. It's not like this. It's like this. So we'll start with a little bit of angle just away from that joint. Let's say we're doing the right joint. The patient's looking down. We'll toe a little bit away, okay, and then I'll put the needle down right here, and then I'll walk it right into the joint, and then once I think I'm in the joint, I'll ask Michelle to just go a little more AP, just like that. Make sure that the needle's in the joint. Maybe you can go a little more. Make sure that the position doesn't change on the screen, and then I'll inject the contrast. If we're in the right spot, then we'll inject the medicine. And the same thing on this side. You know, it's towed a little bit away from that actual side. The next thing is when we do a knee injection. Generally, if we're in this room and we're doing a knee injection, the purpose of the knee injection is a diagnostic injection. And the reason we're using the x-ray is to know, beyond a shadow of a doubt, that the needle is in the joint. There's a fascinating paper that was done about maybe 15 years ago, and it was done on orthopedists who generally think themselves to be really good at doing knee injections, right? So what they did is they gave the syringe and the needle to the orthopod. They did it blind, they palpated, scrubbed the knee, and then they took an x-ray of the contrast that they'd injected. 30 to 40% of the time, they weren't in the joint, which is pretty shocking when you think about it. You think, yeah, that's got to be the easiest thing to do. So, when we're in this room, we're doing a knee injection, generally it's going to be on a replaced knee, okay? And the reason is, we're going to subject this patient to some risk. Putting a needle through their skin and into their knee, we better make sure that we take away all possibility that we could be in the wrong place. Not only that, if we assume, let's say we numb up the knee, and we assume that the needle was in the right place, and we assume wrongly it was in the soft tissue and the patient got no relief, we may think we may make a bad medical decision, because guess what? The needle was in the wrong place, patient didn't get any relief, and we assumed that we were in the right spot. So by doing it under x-ray, we know beyond a shadow of a doubt that we are in the right spot. So, being in the room, what we do is we put the patient in the supine position, and that way they can lie on their back and have a bent knee projection. It's easiest for us to do bent knee. We can either go on the outside or on the inside, on either side of what's called the patellar tendon. We can do the exact same easy, painless injection when they're lying on their back with their knee bent. So, what happens? We'll have them lie down, and then what we'll do to confirm is we will take a lateral. We don't necessarily need to do an AP projection. that we have to fight with this C-arm to do the AP. When we do the lateral, we will see this picture, okay? In this picture, you'll see the needle coming in through the skin, and then it will go into the joint. Now this is a picture of a non-operated knee. But when we inject the contrast, you would see the contrast squiggle through the joint like this. If it's not squiggling through the joint, you're not in the right spot. But the positioning is in the supine. Generally what we do is you can even take an AP to make sure you're in the right spot, but then to confirm, and also, because now we'll have one of the knees bent and one not bent, we'll have the non-bent knee down, and then the bent knee up. We'll focus this right on the bent knee, and then we'll prep the patient's knee, eventually prep it just like we're in the OR, just like we're going to do surgery, gown, mask, etc. And then we do the injection. So that's the knee. Now, we also do something called genicular nerve block and ablation. They're virtually the same in terms of needle placement. The concept is the patient again in the supine position, they're looking up, their knees out, and generally what we try and do is put a little bolster under the knee that we're going to be working on, or the other knee, doesn't matter, just so that when we take a lateral, we're not looking at two knees superimposed on each other, because then it just clouds the picture. So one's up a little bit. So they've got a bolster, they're prepped, etc., and draped. So what we're trying to do is put the needle right on the epicondyle, is what we call it. And so we've got basically 3 needle positions that we're going to use. Okay? And this is an article by Choi on genicular nerve ablation, just to give credit where it's due. But you can see this needle's down over, and it's sitting right on the medial epicondyle. This one is on the lateral femoral epicondyles. This is the femur bone. And then this one's on the medial tibial epicondyle. There is none over here next to the fibula, which is on the lateral. You ever see a doctor put one there? Stop them, because that can be dangerous. Okay, the nerves that go down the foot are in this area, so don't do that. But you will confirm, that because in one projection it may look good, but you don't know your depth until you take a lateral, and that's the whole point of bending the knee or having the bolster under the knee. So under the lateral, the tip of the needle really should be about a little beyond halfway, maybe even 2/3 of the way down. You don't want it down here in the soft tissue. You really kind of be wasteful to have it down here. Right there is probably the best, where it's just right over and maybe a little beyond the midline section of both of these bones. Here, the tibia and the femur.